my name is KP Balan. As some of you guys know me as a clinical tutor, I'm also a resident medical officer here in Perth. So, I'd like to start off today's session by saying thank you so much for all of you guys out there who have been leaving those positive remarks and wishing me well, and for all those comments down below with your questions. It really makes me happy, and it really makes me happy and motivated to do more of these videos to help you guys out. And please guys, keep tagging people who you think would benefit from my videos. I'm more than happy to help. And thank you so much for watching and following my videos. Now, let's get right to it. So I apologize that I haven't released the video last week. I was kind of thinking, what do I do this week? And because we've talked about the AMC Clinical 2, the preparation, we've talked about observerships and interviews, and those of you guys who haven't seen those, please do go back into my group and you can definitely see them there. And so today I was like, you know what, let's do a little different. Let's just jump right into the AMC clinical cases, because that's what I'm all about. Before I do start, I do want to say something. I think during this tough time of preparing for the AMC clinical exam, positivity and having people encouraging you and also not going against your decisions is very important. So people out there who have done this exam on their own and have passed, that is absolutely amazing. And you know what, a lot more people out there can do it on their own, but there are people that also require help, and that is not a bad thing. It actually sets you to your goal, and if you need it, you ask for it. So guys, no negative feedback about other people's choices of getting a bit of extra help from a clinical tutor. And I'm not saying this is because I'm a clinical tutor, and this is not to offend anyone in any way, but I would just like to encourage people to keep those negative comments to themselves and respect other people's wishes and their actions, all right? So with that note, I like to just jump right into the AMC clinical exam, all right? So today what I decided to do was kind of talk about all the red flags that I've seen lately and all the questions that have been asked to me by students. And these are my own students, by the way. So, but before I do, I'd like to talk a little bit about the differential diagnosis. Guys, when you're practicing, please make sure you do 10 differential diagnoses when you practice. That's a given thing, because it is very important. When you go to the exam hall, you're going to freeze, and that is, everyone's going to freeze. I mean, you may be really confident, but you're going to have jitters, and you don't want the jitters to get the best of you. So practice 10 differential diagnoses, and when you do that, for example, when you have a guy with chest pain in the stem, think of outside the heart, think of the lungs, think of the GI system, think of the psychogenic aspects of it. It could be a panic attack or a PTSD. So think of a holistic approach to a case and come up with 10 differential diagnoses, okay? Some cases are a bit tougher than the others. I do agree with you on that. Now, moving on. Let's talk about a bit about guidelines. So, when you are looking up the cases, when you are getting up the differential diagnosis, I see all the people out there putting up their differential diagnosis to help each other, and that is absolutely amazing. But guys, please do make sure that the differential diagnosis makes sense and you know the pathophysiology and the mechanism of how it could cause that symptom or how it could fit into that stem, okay? It cannot so we're going to talk about where that has been a situation in one of the cases. So before we move on, I'd like to go on about a couple of guidelines. So for PEDS cases, PCH and RCH guidelines are really good. Do get in touch with them. They do change. Then for OBS and Gynae, King Eddie's and SA Health is very good. For medicine and surgery, RCGP and New South Wales guidelines are really good. And apart from that, psychiatry Beyond Blue is very good as well. So keep checking these because they do change quite a bit. And again, you can use your Murtaugh as well. It gives you a very concise and a holistic approach to the case as well. So now, today what I'm going to do is I'm going to talk about 2 cases. And each week I think what I'm going to do is I'm going to talk about 2 cases and red flags that I've encountered that you guys should set yourself straight and kind of rethink the whole approach. All right? So today's case, what I'd like to talk about is the thirst case. So there was a case about a 50-year-old lady that has come in with increased thirst. And in one of the recalls, someone did post a normal BSL level. Now, I definitely put hyperglycemia in my uncontrolled diabetes and hyperglycemia in my differential diagnosis, and even complications of hyperglycemia. But however, if a BSL is given, I would keep that towards the end of my differential diagnosis, all right, and say it's highly unlikely. But in this case, someone had posted it is a side effect of vitamin D. Now, think for a second. Vitamin D is a relatively safe medication, all right? Side effect of vitamin D is usually nausea, all right? And is widely prescribed for a reason. Now, so understand, so here's where I like to point out. Vitamin D itself doesn't cause the polydipsia and the weight gain. It is mainly when it's prescribed to individuals with normal calcium levels. You prescribe vitamin D injections or vitamin D supplements, and when it's taken over an average amount of time, it causes hypercalcinosis. Hypercalcinosis causes polydipsia, polyuria, and weight gain. Okay, so that is a side effect of hypercalcinosis, and it's not a side effect, sorry, it is a symptom of hypercalcinosis, not a side effect of a vitamin D, all right? So that is where that kind of plays into that case. And then apart from that, it can also be other reasons of hypercalcinosis that you should be including in your differential, such as primary and secondary hyperparathyroidism. So that is also something that you have to think about. Then malignancy that can cause hypercalcemia. So you see, those are right there you have 4 differential diagnoses already, and then you can include hyperglycemia or uncontrolled diabetes as a 5th one. So you have 5 differential diagnoses right there. So, and then you have normal dehydration, and you have normal excessive vomiting causing dehydration. So these are a couple of things that you have to think about, all right? So please, this is a case I chose today to accent the fact that please check all the differential diagnoses and how they play into your stem and why that could be a diagnosis or a differential diagnosis for that case, all right? Moving on. I wanted to talk about another case. That was the Varicella guidelines for pregnant or women who are considering to be pregnant. So let's get one thing straight. Varicella, what is it? Chickenpox, all right? So if a woman is trying to get pregnant or thinking about getting pregnant but is not pregnant yet, you do the titers, check if her IgG titers are up and if she has adequate immunity, all right? If she has adequate immunity, then you don't need to give vaccination, okay? Now, vaccination is a live attenuated vaccine. A recombinant vaccine is not available in Australia yet. It is practiced in US, but not here yet. Now, how does this play in? If a woman is pregnant, then you would do the titers. And if the titers are negative, that is IgM and IgG, then I would give an immunoglobulin because that is safe in pregnancy, all right? Now, if she has IgM, that means she's acutely infected, all right? IgG means that she has the immunity, all right? If she's pregnant, she has IgG and she has exposure, I'm not going to really do anything. Okay, you don't need to do anything unless she develops varicella, the rashes, okay? Now, in terms of a woman who is trying to get pregnant and is not pregnant yet, and what I would advise is I do the titer, she's not immune, she doesn't have any immunity, then what I could do is I would check if she's pregnant first. Not pregnant, then I would give her the vaccination, the live attenuated vaccination, and tell her not to get pregnant for the next 28 days and not to try getting pregnant in the next 28 days and use protective measures. So that is part of your counseling, all right? And last but not least, just try to understand that varicella is acutely contagious or infectious at the vesicular stage, and it is a time that you can get contaminated the most, especially school teachers. They come in contact with children. They're usually they can be airborne. Okay, it's not direct contact only, it's airborne as well, and you usually have to have about 10 to 15 minutes of exposure, all right, for airborne. For direct contact, just a direct contact to suffice. So please make sure that check if she's pregnant. If she's not pregnant, tell her not to try and give her the vaccination after the titers checked and that she's not confirming that she's not pregnant, and also to try to, if she's pregnant, try the immunoglobulins, try to explain what IgM and IgG means, all right? So these are the 2 cases I like to stress upon because I know that varicella is a case that has come a couple of times and has caused a lot of questions. So I hope today's sessions helped. If you have any further questions, don't hesitate to ask and drop in the comment section below. And if you'd like any cases to be discussed as well, drop it down below and I'm more than happy to go over them, all right? It gives me a better idea what you guys want, all right? Thank you for staying tuned. I'll see you later. Bye.